symptoms, and then it's really going to stop about that pyloric sphincter, so right there at the lower end of the upper side of the GI tract. Let's start off with cleft lip and palate. So cleft lip and cleft palate, they kind of say them together, but they affect different things. Obviously, cleft lip is going to affect the lip itself. So for instance, in that picture, and then cleft palate is going to affect the palate, or kind of like the roof of your mouth, if you want to think about it that way. And usually the, 4 to 9 weeks of development within inside the womb, during that early development, that's when these soft structures are going to start to close up and try to conjoin together. And so there's some type of anomaly, something that didn't occur, fully fused together, and that's when we develop the cleft lip and the palate. We can have a lot of variations within our cleft lip and cleft palate. It's easier to explain it to you through pictures. So we can have it bilateral, for instance, on this picture on the left right here. And so he has that indention, or kind of that notch on the right and the left side, so we have that bilateral involvement. On the right side, this is more of our cleft palate. So if he had his mouth closed, or the baby had the mouth closed, it would look as if he had nothing wrong, right?
Right.
So assessment is important. Assessment is one of our biggest tools with our diagnostics on the cleft lip and cleft palate. We can also have both of them combined together. So maybe on the left, we have that cleft lip, but on the inside, we also have the palate that didn't form or fuse properly together as well. So these are really good pictures, kind of get you an idea of what we're looking at, okay? Can be caused by a lot of different things. Sometimes it's a little more hereditary. Maybe it's tetragenic, so something the mother took during childhood development when she was pregnant in those early stages. There's a lot of medications that can cause some harm to the fetus, to the child. So maybe it's something of that. Maybe some type of environmental factor as well. Maybe there's secondhand smoke, or she's smoking herself. Alcohol can play a role in this as well. So there's a lot of different things that can cause some of these malformations. What are we at greatest risk for? So big one's going to be nutrition. If we think about a child, a small infant, baby, how are they going to feed? They're either going to nurse, or they're going to breastfeed, or they're going to be bottle fed. If they have some kind of structural deformity, that's not allowing them to get that good, adequate seal around the nipple of the bottle or the breast, then they're going to have some kind of delay where they're not able to get in those adequate calories that they need to intake, or it's a real slow, long process of them breastfeeding or bottle feeding. They're also at a great risk for aspiration. So if they have a hole in the back of their palate, when they swallow, could it go into their trachea?
Absolutely.
Exactly. It's all tied together. All right. And then hearing loss. Why hearing loss?
It's all connected.
It's all connected. Again, that's not a really good representation of the picture of it. That's just a generalized picture. But with some of the musculature within your palate, within your lips, also control the pressures within your middle ear as well, allowing air in and out. If they're not adequately able to control those movements of the middle ear, then they can have a greater risk for ear infections. They can also get a backflow of fluid, maybe a little bit of formula or something that can kind of backflow in there depending on where the milk or formula goes. And so these repeated ear infections, that repeated amount of increased pressure within the middle ear can increase our risk for hearing loss as well. Speech deficits. So babies are starting to speak, starting to babble a little bit. Even in those first couple of years of life, if we don't get this treated right off the bat, then they're gonna have some speech delays. But mental health in there as well, it's really hard to assess the mental health of an infant, but we're thinking about the mental health of the parents, okay, as well. The parents are really excited that they just had a new baby, a new child. Right? They wanna show it off to the world. They think it's cute and just beautiful work of nature, and it is. But they may be a little hesitant because their baby has some type of deformity, maybe some type of cleft lip, and so they're not wanting to show off their child. And maybe I did something wrong to cause this. It's my fault that I caused this cleft lip or this cleft palate. So we also need to check on the mental health of the baby as well, of the parents as well. Right. When we are talking about interventions, we have surgical management. That's going to be our category, and then we're also going to talk about nutrition management as well. That's going to be your two big ones with your cleft lip and your cleft palate. Let's see if we got a picture. Yep. Nutrition wise, how do we assess that they're getting adequate nutrition? Weight, okay, good. What else? Intake and output. So if they're having wet diapers, and they're adequately hydrated, right? The decreased amount of wet diapers they have throughout the day can be an early sign of dehydration. Maybe we can look around their lips. They're a little bit dry. They're not be a little dehydrated. We also look at their weight as well. Babies are supposed to gain weight. They're supposed to grow. But if they're not, then they're not getting that adequate calories, that adequate nutrition as they should. So they have lots of different bottles, lots of different techniques that they can use to encourage good nutrition. I have a lot of formula that they can drink, and so that's what we're going to go for. If you see that bottle right there on the left side, it's got a really long nipple on it. A lot different than just kind of standard nipples. I don't have a standard nipple up here, but we're able to kind of put this in the back of their throat, maybe kind of get it past the deformity and really put it back in that subbuccal area, kind of along that cheek and that teeth line, that gum line right there. And it allows us to control the amount of volume or flow of that formula that we can get into. This is gonna help us decrease the risk for aspiration at the end of the day. Right? So we put it back in that subbuccal cavity. We're only giving them small amounts of formula at one time. It's not just a sudden gush like the gulping formula. We're able to hopefully reduce that risk for aspiration. You see here on this right side, we have a cleft palate as well and a cleft lip. Over on the far right, we have this cleft palate, and we're not putting the nipple inside the cleft itself. We're kind of letting it rest right on the outside. If we put it right side of that palate, it encourages the formula to go other places. It doesn't encourage the formula to go to the back of the throat, down into the esophagus. What other things can we encourage to do when feeding? Increase nutritional position of the baby. All right, how are we going to position?
More upright?
More upright positions. We're not going to let them lay down. We're going to have them more in that upright position, not really in that supine position like we typically do sometimes. What else?
Burp more often.
Burp more often. Good. So we're not going to rush through our feedings. We're going to take adequate amount of time. So that real slow, steady pace. We're not letting them gulp down their formula, their bottle. And then we're going to stop frequently to burp. Anybody think of anything else? We can also do small frequent feeding as well, not just one big bottle in the afternoon and one big bottle in the evening, which is normally you're gonna feed a kid every couple hours anyway, but. Moving on to the surgical side. So with the cleft lip, we really want to do early intervention as much as possible. We're gonna fix the cleft lip before we fix that cleft palate. So we're do surgical intervention where they kind of combine the tissues and have that surgical repair. Usually that's going to occur in that 3 to 6 month range of life. and then they can come back and fix that soft palate, up to a year. Really wanna get that early intervention, so their speech is not affected, and also just overall reduce that risk, for nutritional deficits, aspiration risk reduction as well. Furthermore, I know they're not in speech therapy, they're not speaking right now, but speech therapy and occupational therapy, can encourage us, have some teaching techniques, encourage the, parents on different ways to feed them. Yes,
I'm just curious why we want, like, say the child has both a cleft lip and a cleft palate, why would we wanna fix the cleft lip prior to the cleft palate? I would think that the cleft palate seems.
so the cleft palate is still kind of growing and
Yeah.
molding. The lip is more pliable and easier to develop. The cleft palate, they still want it to kind of mature fully, first within that first year of life, and so that's when they're gonna delay care on it as well.
Okay.
And you don't wanna double the surgery too. It would be just almost, barbaric on the baby and very hard to manage, outpatient wise, so. And parental involvement. So remember, we're talking about mental health. So these, parents may be depressed. And so we want them to get involved in their care. Cause they're gonna have to go home with these, infants, and they're gonna have to take care of them individually without our supervision, with our care. So we want them to get involved. Once they start to get involved, if they're more comfortable around their children, their infant that has that cleft lip or that cleft palate, and they kinda become used to it, and they're not as depressed a state as they are. So it's not really that shock factor anymore, because they're used to it. With your surgical education, post-op wise, our biggest concern is gonna be risk for infection, and then with the infant playing with the surgical site itself, okay? You can't tell an infant or a small baby, 3 to 6 months old, don't mess with it, right? They're all wiggly and squirmy, have their little fingers and toes, and they're just curious, right? So they're gonna, try to pick and pull as much as possible, right? We may need to restrain them, or even maybe just put a little sock over them so they can't grasp or pull at that, surgical site. Maybe some kind of big extra protective bandage over the surgical site itself, so they're unable to pick at that surgical site itself. What about positioning? What position do these infants need to be in? Upright, okay, good, what else? Opposite side. Good. Well, wherever the cleft lip, cleft palate is, the surgical site is. So, say they have a surgical repair of a cleft lip on the right side, we can lay them on their left side, correct? Or for their tummy time, kind of on that left side. If, they lay on that right side, there's a chance for them to scrub or hit that surgical site and cause more injury. Bilateral, then we're gonna set them supine. 9 times out of 10, we're sitting the baby supine anyway, so we don't have to worry about positioning itself. We're not really putting them in the prone position, especially when they're sleeping, because we talked about SIDS a while back. It's mainly just trying to, make sure your parents are aware of the potential risk for them to aggravate that site further. Same with, what's up?
Okay, let's say you have a 3-month-old that's not rolling over yet, what, like, and they have a right side, why would you still lay them on the left to go to sleep? I thought they would always.
Not to sleep, but if they're just like normal everyday, life, if they're rolling on their side or something, doing like a diaper change or something, you're gonna try to, if you have to roll over a certain situation or something, you're gonna try to take special care and only roll to that left side. When they're sleeping, you're also in a supine position. That's your question?
It is.
Yeah.
So they have the surgery, obviously, you notice they're wrong.
Yes. And so it's really up to physician, preference on time bottle feeding, when to introduce feedings back again. And that's the same with cleft lip and cleft palate. Cleft palate is very similar in education as cleft lip. It's a little more advanced because we have to pack the oral cavity as well. Usually it's gonna be packed for 2 to 3 days, and then they'll, depack it. And they'll kind of evaluate, see how the wound is healing, and go from there. We're really gonna try to reduce the amount of times we introduce anything harsh into the baby's mouth. So anything that's real hard or wiry, so you want it as soft as you can. Nipples, we're not directly touching that side with the nipples. We're gonna try to put it off to the side, run them together. Probably won't allow pacifier, for the next few days, few weeks, until, the physician says you can. Again, we're gonna monitor for signs of infection. What are we gonna teach our parents about infection? What do they need to look for? Fever. Okay, what else? Discharge, redness. What about irritability? The baby's just real fussy. Is he gonna be able to tell you he's in pain?
No.
No, probably not. Or that he has drainage in his throat. Also swallowing, maybe. So we need to talk about those things with our parents. Definitely get occupational therapy, speech therapy involved as well. They're really gonna help us with feeding techniques. And then as they progress further, if they have some type of speech delays, because we didn't jump on this fast enough, then they can also help with, speech involvement, speech improvement as well. Right, infant has just returned to the nursing unit after surgical repair of a cleft lip on the right side. Nurse replaced the infant in which, best position at this time? Good. Answer choice C, left lateral position. Does that make sense for everybody? Prone and on the stomach are the same thing, so we can go ahead and cancel those out. And then you had a surgical repair on the right side, so definitely want to put it not on the right side. Any questions about cleft lip or cleft palate? Let's talk about GERD, or gastroesophageal reflux disease. So we've all heard about heartburn. So this is gonna be a little more advanced heartburn if you wanna think about it that way. So it's the continued backflow of stomach contents and acid out of the stomach back up into the esophagus. Esophageal sphincter, the lower esophageal sphincter is compromised in some way. It is more dilated out, not constricted down, allowing for that backflow to occur. More chronic in nature, it's not just occasional, it's constant every single day. Constant symptoms, pain, that's when we're gonna kind of classify it as that gastroesophageal reflux disease or GERD. With our risk factors, and again, I said it's gonna mostly deal with that lower esophageal sphincter. So right at the end of the esophagus, right as it transfers into the stomach, that sphincter closes, doesn't allow for food to enter or backflow out of the stomach. And that's what our risk factors are going to revolve around. With nutrition and diet, there's certain foods that can actually kind of aggravate that sphincter. So things like caffeine, alcohol, chocolate can help with that. We just have acidic in general foods as well that can cause a decrease in our pH, a more acidic pH of our stomach. So things like orange juice or tomato sauce, sausages, things like that. Why does NG2 matter? Anybody have any thoughts? Good. Hold it open. I like it. So I have a slide right there. Again, so like I said, here's your lower esophageal sphincter that's holding tight, holding it closed, allowing for that stoppage, not allowing for that backflow of that gastric contents. When that sphincter is open, that's when we're gonna have that reflux. So if we have an NG tube, we gotta imagine it's going through the nose, down the esophagus, down into the stomach, okay? So that's gonna allow for this to remain open, not allowing for that tight closure, that tight seal of the sphincter to occur. So we have that NG2, then we have that increased risk for backflow, for regurgitation. What's gonna increase our intra-abdominal pressure or intragastric pressure? Michelle?
When I answer your question, I just wanted to add to this.
Yep.
Could pyloric stenosis be also included in this?
Maybe.
I just kinda wanted to think about it, cause I had pyloric stenosis when I was a kid. And so my mom said like when I was a baby, I had like terrible acid reflux, until I like got the surgery to fix that.
Yeah, so with pyloric stenosis, we're gonna talk about in a minute, it
We're
does
gonna talk about it, okay.
cause a backflow
Yeah,
of gastric contents, which then would affect our lower esophageal sphincter, that could cause reflux, so.
okay.
So gas, increase the pressure.
Gas can increase pressure, okay, what else?
Pregnancy.
Surgery.
Pregnancy, good, so if you have a baby swimming around in you, that's gonna increase your abdominal pressure, right?
Bowel obstruction with that.
Bowel obstruction or your pyloric stenosis, that could be kind of on the same lines.
GI tract.
Yeah, so what about, a lot of ascites or, a lot of adipose tissue in your stomach? I got a lot of adipose tissue and I have GERD, so it kind of goes hand in hand, right? What about positioning?
That's right.
That make sense?
Yeah, because you lay down, it flows back.
Lays down, so you're naturally allowing gravity to let it flow backwards, right? So we're gonna allow for that high phallic position.
And if they eat more, it's
So if they eat, we're gonna let them sit up for a while. What about prone positioning? Is that gonna increase our intra-abdominal pressure?
Yes.
Good, so we have to watch out for that. We'll talk about prone positioning when we get to critical care. We like some prone positioning in critical care. All right, got a lot of signs and symptoms that can occur. We look at page 1137, box 46.6. Gonna have all the signs and symptoms that you ever want for GERD.
What was the page on?
Page 1137, box 46.6. So we've got things like dyspepsia. What's that? Indigestion, good. What about odonophagia? Swallowing, good. Globulus? Lump in your throat, or feeling full, fullness in your throat, how like something stuck in the back of your throat that you have to get out. Pyrosis? Heartburn, good. Have some pain in there as well, some nausea. Biggest concern with GERD, what can these symptoms mimic? Heart attack, good. So they have chest pain, chest tightness, they're having some kind of burning sensation right here. The esophagus is right in line with that as well. Indigestion, there's a lot of pain, a lot of nausea involved. Is it your heart, or is it just your acid reflux acting up? So how could we tell? EKG, good. We do that. They also have this magic cocktail that they'll give in the ER a lot of times. So it's a combination of a lot of stuff. Bella, you know what that is?
I forget what's in it.
So it's got a little bit of lidocaine in there, it's got a little bit of Maalox in it as well. Sometimes they give them protonics, IV protonics as well. We'll talk about what that is in a minute. So it kind of numbs that esophagus, tries to treat that indigestion. If their symptoms go away, then is it a heart attack?
No.
Probably not. Alright, if their symptoms persist, then we need to do some further work there. If anybody says chest pain in the ER though, they're gonna go cardiac route first anyway, so, if EKG is normal, and then they get that magic cocktail, and their symptoms improve, then we know it's more acid reflux based. But in the back of your mind, we can think that GERD mimics the signs and symptoms of Patient education. Lifestyle modifications to decrease intra-abdominal pressure. What can we tell our patients to do?
Not eat late night.
Not eat, well, yeah, that's good. To decrease intra-abdominal pressure, what can we tell them?
Lose weight.
Don't eat beans, lose weight. So yeah, don't eat beans, we'll reduce our gas content, right?
Smaller meals.
Smaller meals, good. Movements, so we're gonna try to limit the amount of bending over at the waist we can to kind of prevent pressure on that intra-abdominal cavity. What about positioning? We talked about prone positioning, so maybe they need to sleep on their sleep on their side, or maybe sit in that upright high Fowler's position. Seen a lot of patients even put blocks underneath their bed, and so it elevates their bed up a little bit, elevates the head up a little bit. A lot of them will sleep in a recliner, which is where it makes them feel most comfortable, especially when they're having kind of an acute attack. What about losing weight?
Yeah.
We're always gonna encourage our patients to exercise, right? Nutrition management as well. Again, this is a how, what, when, where situation. How often do they eat? So are they doing 3 large meals a day? Or can we encourage them to do small meals a couple times more throughout the day? Those small meals are going to overall reduce how much pressure we have within that gastric cavity, within our stomach. When do they eat? Are they eating right before bed and then they're going right off to sleep? So they haven't had adequate time to digest. So we need to really encourage them at least 3 to 4 hours before they go to bed to kind of finish eating whatever they're gonna eat. What do they eat? So we need to limit foods that are going to compromise our lower esophageal sphincter. So things like alcohol, caffeine, chocolate. We also need to reduce how many acidic foods that we're going to eat. So orange juices, again, the tomato sauces, a lot of spice, maybe a lot of hot sauce. Coffee will do it to you as well. Maybe cayenne pepper, something like that. What'd you say?
No fried foods,
No fried foods. So basically all the good stuff in the South that we eat all the time, none of that. Drug therapy. We're gonna talk about drug therapy in a minute. So we're gonna talk about medication management and how we go about that. And then we're also gonna talk about surgical management as well. All right, with our antacid class, we have magnesium hydroxide with aluminum hydroxide. We have just aluminum hydroxide, and then we have calcium carbonate as well. Anybody know what those are? Tums, like Tums is a calcium carbonate. What about aluminum hydroxide just itself?
Maalox.
Maalox, good. And then the first one,
Magnesium.
magnesium hydroxide with aluminum hydroxide.
Phillips.
Mylanta. With antacids, we're deactivating pepsin, which pepsin breaks down some amino acids and some proteins within your stomach, and that will overall lower your pH of your stomach, so creating a more acidic environment within your stomach. With antacids, we are blocking that mechanism altogether, so we're effectively increasing our pH, making it more basic, not as acidic, to hopefully reduce those type symptoms. We'll interact with several other drugs. Patient education wise, electrolytes is a big one. Sam, you've talked about this 100 times in clinical, but it can increase your magnesium level, right? Because it's part magnesium. So if they're just taking these one after another, maybe we need to monitor their magnesium level. They can have hypermagnesia. Same with the calcium carbonate. If they're popping one Tum after another all day, every day, with no symptom relief, which a lot of them will do, and they're just eating it like candy, you can have some high calcium level as well. It can also affect our bicarb levels. And so, if your patient's in metabolic acidosis, we can give them some Tums and hopefully treat that and correct it. Kind of off-label use, but. We have our H2 antagonists, our blockers. So we're gonna effectively decrease how much acid is being secreted or produced with that one time. All these are gonna end in DINE, D-I-N-E. So we have famotidine. Everybody should be familiar with that. Everybody know what that is? What's that name for? Pepsid, good. We have metazidine as well, and then we have ranitidine. Ranitidine's another pretty common one that you will see. Ranitidine is Zantac as well. For these, we're gonna give them just one dose right at bedtime. And that's how we're gonna effectively treat that. So a lot of y'all have given Pepsid at night with those. So we're decreasing our gastric acid production. And that's gonna be important a little bit later on. All right, we have our proton pump inhibitors as well, or your PPIs. This one y'all are also very familiar with as well. The one you're most familiar with is pantoprazole, which is also gonna be protonic. We also have omeprazole and lansoprazole as well. So they're all gonna end in zole. Don't get them confused with your fungal class. All right. So I see that mistake a lot. Don't get them confused with your fungals. Omeprazole is your Prilosec, and your lansoprazole is your Prevacid. We'll write that down. PPIs will interact with a lot of other drugs, with also certain foods as well. Typically we want to start this about 30 to 45 minutes before a meal, so you're usually going to take this in the morning for breakfast. So wake up, take this, and then 30 to 45 minutes, eat breakfast, kind of go on about their day. Typically we're never going to crush this. They have an IV form of it as well, so that's when we're going to use it most often. PPIs as well, the greatest risk for long-term use is going to be osteoporosis. So we really don't want them to be on PPIs long-term. I'm just going to risk it and hopefully not get osteoporosis. I really like my protonics a lot, so I'm just going to keep taking it, see what the best is. But for elderly patients, for the female population, that already went through menopause, maybe we need to consider other options besides a PPI, which there are a little bit of risk for developing an osteoporosis and maybe some type of fracture or something like that. Little math for you, Sam, don't answer. Provider orders 40 milligrams of Protonix IV to be diluted in 100 milliliters of normal saline and infused over 15 minutes using an IV pump. What is the infusion rate in milliliters per hour? Give me a second. Somebody got the answer?
400.
400? Yes, 400 milliliters per hour. That makes sense? You need to work down on the board? Internet, everybody got 400? Sam, you get 400?
100 times 60 divided by 60.
Okay, that's not the way I work it. Everybody got 400? Good. All right, how do we treat GERD surgically? We do this procedure called a Nissen fundoplication procedure. It's going to be kind of a laparoscopic procedure. Usually they don't open them up all the way. Yeah. So with this is our diaphragm right here, this thick line, thick barrier right here. And with our stomach, it's actually protruding up and out of the diaphragm, and we have to call that herniated portion within the stomach. So it's protruding out of the diaphragm itself. And it's compromising our esophageal sphincter. Right? So with the Nissen fundoplication, we'll actually take the upper part of the stomach, or the fundus itself, and we'll wrap it around the upper part of the esophagus, kind of around that esophageal sphincter, and kind of have that tight connection, and we'll sew it back to itself. Okay. This is good for hernias, but it's also good for GERD as well. This is kind of the last resort option for GERD. All right. 9 times out of 10, it's going to be on some type of medical management, lifestyle modifications. If they're still continuing to take their medication as prescribed daily, like they should, they've implemented those lifestyle modifications like they should, and they're still having constant symptoms, and I'm talking about like severe symptoms where they're throwing up all the time, they can't go on about their ADLs, this is something we would consider for our patients. Otherwise, they're not gonna put them through surgery just for a simple heartburn, simple GERD. So if you let GERD go untreated for long periods of time, we can then go into this class, or this disease process, of peptic ulcer disease. With peptic ulcer disease, we have some type of disturbance within the mucosal lining of the stomach, some kind of breakdown, some type of tear, a little ulcer that has developed somewhere within the mucosal lining of the stomach. Depending on where it is going to be what type of ulcer or class that we put it in. So we have a couple different types. We have duodenal ulcers, gastric ulcers, and we also have some that will be developed from stress, and we'll call those stress ulcers as well. Generalized for our signs and symptoms are going to be roughly the same thing. Like I said, depending on where the ulcer develops, it's going to be what we're going to classify the ulcer as. So we're going to have some epigastric pain. It's going to be sudden, sharp, and acute when we have this. They're going to be real guarded is not really a word. They're going to guard their stomach. And so they're not going to really want you to palpate on their abdomen. So when you do your abdominal assessment, they're going to scream out in pain, not really wanting you to touch it. It's real tender, sharp type pain. And then dyspepsia as well. We may also see some abdominal distension, so it's real tight, real firm when we press down on it. And they're also going to have a couple other symptoms, so they may develop some dyspepsia or some of that chest pain, some of those symptoms that we had for GERD. We're going to have the same symptoms as peptic ulcer disease. So a couple things that we're going to test for and to either diagnose or confirm a type of ulcer or rule out an ulcer for other potential issues. We're going to do some H. pylori, which is a certain infection that will cause an ulcer. Because it compromises our mucosal lining, it will affect our mucosal lining, so we're going to get that out of the way. We're also going to do what's called esophagogastroduodenoscopy, or an EGD for short. So it's real long term. Remember that spelling because you're going to have to write a lot of consent forms for EGDs and you have to spell them out these days. Anyway, so with EGD, they're going to go take a camera and run it down your esophagus. Look at all the linings of your esophagus. Make sure you don't have any esophageal varices that are bleeding, anything like that. But then they're going to go further down to within the stomach, and then they can look around and see if there's any type of ulcer that has developed. Is there any bleeding that they've noticed? And they can even go a little bit further, kind of into the duodenal region as well, and see if ulcer or some type of perforation or something has occurred on that end. After that, they're going to go the other way. And that's called endoscopy, so that's a little bit different. So if we're worried about some type of ulcer or perforation, some type of lower GI bleeding that has developed, then we're going to go through the rectum in that direction as well. Okay? So we can't take a camera all the way down out through the rectum. That'd be very, very weird as well. Like I said, ulcers are gonna be classified depending on where they are occurring. So your gastric ulcers, typically they occur in the bend of your stomach right here, that curvature of the stomach. So that's gonna be any type of gastric ulcer. It can occur really in any stomach area within there. The duodenal ulcer is gonna be past that pyloric sphincter, just on the other side in that first little section of the duodenum. And that's where the duodenal ulcers are gonna occur. Yes?
Did they ever use the camera, the swallowable camera?
That takes a while to work. They can use it. The EDD is a little more fast and efficient for emergent situations. Like I said, the duodenal ulcers occur in the upper part of the duodenum. Once they start getting into that small intestine, we're not going to classify it as that duodenal ulcer. So we have high gastric secretion content, acidic content, that is then flowing further downstream, if you will. That's going to cause a lot of stress on that region, and that's how we can create one of these ulcers. And we also, if we have a lot of fast moving food, so real fast gastric emptying, we don't have that buffer that food creates within our intestines. So that food paired with that gastric content, that gastric acid, kind of dilutes it out. But if we don't have a lot of food within our system, or maybe we have maybe a stomach bug with a lot of diarrhea, or we're going the other way where we're vomiting a lot, we don't have that food to dilute out that gastric acid, and when these can occur. Like I said, gastric ulcers kind of really anywhere inside the stomach. It usually occurs in that bend or the atrium of the stomach. The H. pylori infections can cause these as well. With gastric ulcers, we actually have the reverse effect. So with duodenal ulcers, we had fast gastric emptying where the food was moving through rapidly and that acid was left over and it wasn't diluted out. With this one, the acid is actually staying in the stomach for a long period of time. So anything that is going to kind of delay that emptying, so it could be that small bowel obstruction or that pyloric stenosis that we're going to talk about a little bit. Then we have things called stress ulcers.
We all
So it's really any kind of stress within the body that can occur. So you're really anxious about something. So if you're in nursing school, for instance, you are NPO for long periods of time. You've had some kind of recent surgery. Maybe you were in a really bad car wreck, so you had some big trauma, sepsis, so infection kind of throughout the body can develop a stress ulcer. So what do we give all our patients before surgery or after surgery? Or pretty much any patient in general that gets admitted to the hospital, what are they on?
Heparin.
Well, heparin, yes.
Mylanta.
What? Mylanta, so they're on some type of antacid, or they're on some type of H2 blocker, or they're on a PPI. So you're giving them Pepcid, you're giving them famotidine there, you're giving them pantoprazole or Protonix, you're giving them something for indigestion, so maybe an antacid of some sort. So you start looking when you go to the hospital, how many patients are on some type of treatment for GERD. It may not necessarily be for GERD. Maybe it's to reduce or prevent the risk for stress ulcer. Okay. A lot of people will get diagnosed with GERD or acid reflux, but again, we're treating for risk for stress ulcers. This is really an emergent situation that these start to develop. These like to bleed a lot. All right. How do I know the difference in, say, an upper GI bleed for like a stress ulcer, for instance, or if it's a lower GI bleed?
The color.
The color, good. All right, so what type of color is going to be the upper GI bleed?
Black. Dark.
For upper?
Oh,
The lower is black.
Yeah, so lower is gonna be black. So your upper GI bleeds is gonna be fresh, bright, new blood. All right, it hasn't had a chance to get digested yet, mixed with that gastric acid content. So it's gonna kind of look like an arterial bleed, and they're gonna bleed a lot. They're gonna throw up a lot of blood. They're gonna be really nauseated. Versus your lower GI bleed is gonna be more of that black, that tarry, they call it, write it down, melena, M-E-L-E-N-A. So that's that dark tarry stool that you're gonna see develop. So when you have a lower GI bleed, that's what you're typically gonna think about. I'm sure somebody's had a GI bleed while they're in clinical, and so they're stooling a lot. They have a lot of those clots developing that are coming out as well. It's a lot of different things. All right, with ulcers, what can happen? So if we don't treat these, we go a long time or delay in care, we can actually have a perforation occur. Right, so the mucosal lining has broken down so much that it actually puts a hole within the stomach. And then where's all our gastric content going to be?
You're about it.
In your abdominal cavity, your peritoneal. Sepsis, good. Maybe hypovolemic shock. What else are they going to complain of? If we have a perforation. Is that what I got there? Peritonitis, so they're going to have a lot of pain associated with it, a lot of acute pain. They may be in pain already from an ulcer, but they're going to have really sharp, increased intensity of pain. They're going to have that rigid abdomen. We might start to see some bruising or shadowing occur when we're doing our abdominal assessment as well. We can also have a pyloric obstruction as well. And with that pyloric stenosis, we're going to talk about that in a minute, but that pyloric sphincter, which is at the very bottom end of the stomach, in the junction with the duodenum right there. If we have frequent ulcers that have developed and then have been treated, we can start to have that scar tissue develop, and we can actually cause an obstruction altogether. And so we don't have anything going further downstream, if you want to say it that way. And then we talked about hemorrhaging, so we talked about upper GI and a lower GI bleed as well. That's an emergency situation. We need to let somebody know. So we need to let the physician know if it's a new onset type thing. So if they're throwing up blood, probably need to let them know. Maybe they need to go have surgery to repair whatever is messed up, right? So that's when we're gonna get EGD involved. They can go down the esophagus into the stomach, look around, and make sure nothing's bleeding. If it is, then they can cauterize it, right? So they can kind of burn it just a little bit. They can also inject epinephrine into it as well and vasoconstrict those little vessels that are within that ulcer to hopefully kind of block off or shut off the excess bleeding that occurs. And then if it's the lower, we're going to do an endoscopy and do the same thing. Not like the page number. Box 47.2. It's in the GI section. I'm sorry, it's not like the page number for that. It's probably going to be 1140-ish range. All of those. That's going to list all your complications for GI bleeding. Just a couple more pictures. So we see a little bit of bleeding here. This is part of our EGD. That one's squirting actively. So that's a real active arterial bleed right there. That's something that they would cauterize up. We have little air bubbles, air pockets as well, so there'd be a little bit of gas, a little gastric content in there. That's pretty cool, just to see. All right, so what do we need to educate our patients on? Any thoughts?
Sounds of bleeding.
signs of bleeding, which can indicate an upper or lower GI bleed. So we need to educate them to what? Come to the hospital, right? Okay. We can also talk to them about signs and symptoms for a potential perforation, right? So that sudden increase of pain, if their abdomen is real tender to the touch, it's real rigid, they're not able to apply pressure to it, it feels like a board-like appearance. Feels like you're pressing against like a 2x4 or something like that. That rigidity part of it, that could be an indication for a perforation. Are they having adequate bowel movements? Are they going regular like they should? What is their baseline? Are they an every other day kind of person? Are they every day at 8 a.m.? Are they super regular? So we need to know those things. If they have any kind of change in it, one way or the other, they're going more frequently or they're not going as often, maybe they have some type of obstruction that we need to take care of. Can't really teach them about vowel sounds, but that's more for us. All right. Nutrition management. What type of trigger foods are going to affect our GERD, so those spicy types of foods, that can eventually play into our ulcer development as well. So those spicy foods, like hot sauces, a lot of Cajun food, that really good food, those types of things, that can be the real spicy stuff. Again, caffeine, alcohol intake can affect these as well. We're trying to prevent another ulcer from developing. That's kind of our big role for education. So we need to maintain adequate weight as well. So if they're too afraid to eat, or if they develop an ulcer and it's delaying the absorption rate of those calories and those nutrients that we need from our food, that can play a role in sort of maintaining our weight. Also encourage that medication management and medication compliance. So the same thing with your peptic ulcer disease is really going to be with your GERD. It's going to be the same management in mind. Nurse is monitoring a client with a diagnosis of peptic ulcer, which assessment finding would most likely indicate perforation of the ulcer. D, rigid border-like abdomen. I like that. Alright, so this is an emergent situation. We need to let somebody know. We can also argue bradycardia as well. So if they lost a lot of volume as well, and that's sick to that point, where they're fixing to go into cardiac arrest. Or they could also have the opposite effect and have some tachycardia as well, with a high volume loss. Their heart is trying to compensate, so we have an increased heart rate. Okay. Nurse is doing an admission assessment on a client with a history of duodenal ulcers to determine whether the problem is currently active. The nurse will assess the client for which manifestation of a duodenal ulcer. Said C. Not you? C's right.
Yeah.
Okay, I will do that.
It was you?
Yeah.
Okay. Alright, so do we remember when I was talking about duodenal ulcers and how food creates a buffer for that gastric acid?
That's
And it
what I was
kind of
thinking.
dilutes that gastric acid content, if you want to think about it that way. And so a lot of times your patients are going to report sudden onset of pain, and then when they eat a meal, it goes away. And that could be a classic indicator for that duodenal ulcer. This is a very good slide. I like
Then
this
why'd you
slide.
backtrack?
Because we both know our wall.
Stand firm.
This is a great slide. Okay. Question? What? Any questions about peptic ulcer disease? Hang with me for a few more minutes. We got one more topic. We're gonna talk about pyloric stenosis. You remember anything about your pyloric stenosis?
I was a little,
I'm sure you were super small.
I was very small,
Did your mom tell you anything about pyloric stenosis?
not a ton, no,
Not a ton.
I threw up a lot and I couldn't keep anything down and I didn't gain weight a lot as a kid. they brought me in because I couldn't keep anything down and I was, had a ton of vomiting as a baby.
A lot of times it'll be projectile too.
Yeah.
Projectile.
Yeah.
Good. That's gonna be your classic symptoms of pyloric stenosis. So what are we talking about with pyloric stenosis? We're talking about that pyloric sphincter, at that duodenal, your gastral junction right here. So that's kind of that sphincter that separates the stomach kind of from your small intestines. With pyloric stenosis, we're kind of a hypertrophic state, or kind of stricture, contraction of those muscles that are really tight around that junction, and it's not allowing for digestion to occur and allowing for things to flow further down. Usually occurs about 2 in every 1,000 live births. There's not really a known specific cause that will occur with pyloric stenosis. They're contributing some to bottle feeding, potential for your mother, if your mother was smoking, preterm infants, they're seeing a lot of occurrences with it as well. So there's kind of some questions as to what is really occurring or what is causing this pyloric stenosis. Alright, so like we said, projectile vomiting. I would probably highlight that if I were you. It could be a little bit of milk or breast milk or formula that's really undigested, and so you'll kind of see that color turn up within their projectile vomiting. Could be a little bit of blood tinge in there as well. It's been so violent that's causing some irritation within that esophageal lining or within that stomach lining as well. You're really not going to have any bile because it hasn't had a chance to digest or to secrete bile to further break down that breast milk or that formula. The other words I would highlight would be an olive-shaped mass. That's kind of important. So when you're doing your physical assessment on your infant and you're doing your abdominal assessment, you've already listened to their bowel sounds, and now you're palpating, you're gonna feel this real hard mass, this olive-shaped mass is what they call it, in that right upper quadrant area, that epigastric area right there. That's where you're gonna feel that olive-shaped mass. What are we feeling? We're feeling those muscles constricting, that stricturing of that pyloric sphincter. That's what we're feeling. It's really tightened up, kind of rigid almost, if you will. And that's kind of what we're feeling. So projectile vomiting, olive-shaped mass. When we have projectile vomiting, and that's not necessarily just true to pyloric stenosis, but vomiting in general for our adult patients, they can develop metabolic alkalosis as well. All of our gastric content, that pH level, that acidity level is coming out, right? What's there to replace it? Not a whole lot. So it starts to become real basic. So we have increased pH, pH greater than 7.45, and then we can have an increased bicarb level greater than 26. All right, so what are we gonna do? We're gonna do surgical management. That's what we're gonna do. Pyloromyomeny. The oral pronunciation, close enough. We're gonna go in and do a small incision within that right upper quadrant, and we're going to actually kind of release that stricture or those muscular bands around that pyloric sphincter. Once we relax those out, everything goes back to normal. We have normal flow, and you go on about your normal life. Pretty simple procedure at that point. Yes.
Will they have like further complications in adulthood? Will they ever come back up, or is it kind of just?
They should be good to go. They shouldn't have reoccurrence of the pyloric stenosis. So, they may have to go back in and stretch things back out, but usually they have to cover one time. Did you have the surgery?
I did.
Yeah.
I've been fine.
You've been fine?
Yeah.
That's your intervention. There's not really any medication management or anything, that's gonna be your intervention, right? They're going to release that tension on that pyloric sphincter. The things we have to educate our patients on, really educate our parents, because we're not gonna educate the infant. Wound care, right? So the little laparoscopic incision, that small incision, we need to keep it clean, we need to keep it dry, intact, right? Educate them on signs and symptoms of infection. So that redness, the erythema, the patient, a little infant becomes irritable, maybe they have some type of fever. Alright. Then feeding tolerance. That's gonna be physician specific, but we're gonna gradually introduce breast milk or that formula. And we're gonna do it real slowly. Alright. As they tolerate it, then we can kind of build back up to their baseline, to their normal, increase that caloric intake. During this whole process, we're gonna monitor their weight, make sure they don't drop too low below baseline, and they can even develop that failure to thrive if this goes untreated for a long period of time. Some parents just think it's really bad reflux and it'll resolve. And then they don't go to their checkups like they're supposed to, or they have an extended period of time where something's occurring and they're not able to get a good assessment in on that infant, and so it goes left untreated for a while. And then even after treatment phase, post-op, we still need to worry about their weight. We also need to worry about electrolytes. We're not absorbing our nutrition like we should. They're not digesting like they should. Of course, dehydration status, we talked about that a little bit earlier. So if they're having wet diapers, how often are they using the bathroom? Are they stooling? A baby pees and poops, it needs to frequently, right? Alright, so if it slows down, we have an issue. Just another picture. So we just have that normal anatomy, and then again, kind of that pyloric sphincter is strictured, not allowing for that food or formula, whatever that we intake, to travel further down. And that's what's occurring for that pyloric stenosis. Child is hospitalized because of persistent vomiting. The nurse would monitor the child closely for which problem? C, metabolic alkalosis. Again, when we're vomiting, we have that projectile vomiting. We're getting rid of all that acidic content within our stomach. And then what's left is more of that basic in nature, so we're gonna develop that metabolic alkalosis. That's not just for pyloric stenosis, that's for everybody in general. Even for people that are not vomiting, that we have an NG tube in, then we have it on wall suction, and we have continuous suction because we're trying to decompress their stomach. We can develop metabolic alkalosis because we're draining out that gastric acid. Nurse admits the child to the hospital with a diagnosis of pyloric stenosis. On assessment, which data would the nurse expect to obtain when asking the parents about the child's symptoms? A, okay. I don't know if I spoke on that one. There's another one. B.
Always hungry.
Always hungry, right? Projectile vomiting, olive shaped mass, they're always hungry, or irritable. Why are they always hungry? They keep emptying their stomach, right? Every time they take something in, it comes right back down. They're not getting that digestion like they should, not absorbing those nutrients like they should, right? So A and B on this one, projectile vomiting and always hungry. Question about pyloric stenosis.